to have two amazing cornea specialists from Ghana. Dr. Seth Lartay is the first ever HCP Cornea Fellow in Ghana, and he is one of the most known surgeons to do the most amount of outreach work in cataracts, as well as complex work in cornea. He is the chair of Ghana in ophthalmology, and he is also one of the spearheaders of eye donation in the country of Ghana. So without further ado, I hand it over to Dr. Lartay, who I have great regard for, to teach us all on chapters 15 and 16. We're going to flip it up a little bit here today.
15 and 16 is what we are going to do. I've put them together into one set of PowerPoint presentation. And so we'll start with the chemical bench. The effect of chemicals on the cornea depends on whether it's an alkaline or acid pH, the volume, the concentration, the contact time, and the toxicity of the chemical that you are dealing with. It's important that residents know how to grade this. There's grade 1, 2, 3, and 4, because grading helps us to prognosis. And so grade 1, excellent prognosis, and grade 4, very poor prognosis. The clinical features that allows us to do prognosis is based mainly on the corneal haze, and then the limbal stem cell, the limbal stem ischemia. And so you've got to know how to do the grading. This is a grade 2, and this is a grade 3 corneal opacity. Now, alkaline bends are more severe because alkaline causes saponification of fatty acids, destroys the lipid in the epithelium, and so surface epithelium is damaged. It penetrates into the corneal stroma, destroying the collagen, and may even penetrate into the anterior chamber, resulting in cataract and glaucoma. And so when the cornea vascularizes, then it's more stable. And the absence of vascularization may lead to the stroma melting. Severe alkaline bends may end up in a tight scalp eyeball, and very poor outcome for the transplants because there's loss of the goblet cells. The option when it's very severe is to do limbal stem cell transplant followed by penetrating keratoplasty or keratoprosthesis. Acid bends, on the other hand, are less severe because acid denatures proteins, precipitates it, and forms a coagulum on top of the cornea. Mild acid bends, just a few epithelial effects, and so there's lower chance of cornea melting acid bends or penetration of the acid into the anterior chamber, except hydrofluoric acid, which causes severe destruction. However, acids can cause severe inflammation and still result in corneal opacities and symblepharon. So even though we've said that is less severe, it can still cause a lot of injury. How do you manage chemical bends? Acute, subacute, long-term. Always do that. The acute phase is urgent, copious irrigation in any neutral fluid that you can lay your hands on, use it. You may use a speculum if you have it, or a Morgan lens, or handheld irrigation, an IV line, or an irrigating speculum as shown here. When you continue the irrigation at a neutral pH using a urinary pH strip, if you don't have it, just keep on irrigating for 30-45 minutes. During the acute phase, you must invert the upper eyelid and look for particles and clean them up. You may want to debride necrotic epithelial tissues. That's important because it minimizes the release of inflammatory mediators and promotes reepithelialization. During the subacute phase, your aim is to decrease the inflammation, control the intraocular pressure, promote epithelialization, reduce matrix degradation, and reduce polymorphonuclear infiltration, which are a source of proteolytic enzyme that breaks down the stroma. Steroids are very useful. They decrease the inflammation and then they reduce PMN infiltration. But you can only use them for 10 to 14 days because you have to stop to allow wound healing to continue and to avoid stromal melting and to avoid infection. So you got to use steroids for 10, 14 days and then switch. Subacute phase, of course, you want to give cycloplegic for discomfort. In the subacute phase, also tetracycline or citric acid, these inhibit PMN degranulation by acylating calcium. Oral vitamin C is very important. It limits matrix degradation. Lubrication, plenty of lubrication promotes reepithelialization of the ocular surface. In the long term, you have to think about whether you need to do tassuraphy, temporal or permanent, limbal stem cell transplant, bandage contact lenses, amniotic membrane graft, symblepharonix, corneal transplants, but the results may be poor if it is severely inflamed or is vascularized or there's limbal stem cell deficiency, in which case you may have to do keratoprosthesis. You may also have burns, heat, thermal burns. Now, heat induces inflammation and stromal proteases are released and the collagen melts. So these can occur at home, hot metals, hot liquids, hot solids at home, at work, but iatrogenic. The fecal needle, it causes a lot of burns. And so corneal edema or irregular astigmatism, wound leaks, thermal burns, because it's usually limited to the epithelium, cycloplegia, antibiotics, short course of steroids, and taper. And if there are devitalized tissues, they can be debrided, and granulating tissue can be removed. Amniotic, in severe cases, amniotic membrane graft may be considered. Cold injury is also possible. Cold affect the pump function of the endothelium. And so patients who have Raynaud's disease, sensory denervation, these are people who are particularly susceptible to cold injuries. Patients may be exposed to UV radiations, arc welding, direct sun viewing, sunlight. Those of you who live in snows, in Nepal areas, snow blindness, sunlap. I don't know what tanning beds are. I've never seen one before. So these patients present with photophobia, foreign body sensations which are delayed because immediately the epithelium is not destroyed. Examination will show eyelid edema, conjunctival injection, and a diffuse punctate epithelial erosion. The epithelium usually heals within 24 to 72 hours spontaneously. So the management of UV radiation is antibiotic ointments, cycloplegia, oral analgesics. Or use a bandage contact lens, or apply an amniotic membrane ring or amniotic membrane graft. Now, radiations. Radiations are very important. You have radiations. Hopefully, we'll never have a nuclear explosion in our lifetime, but yes, who knows? And medical equipment, gamma rays. Now, radiations directly kill cells. They destroy the DNA, causes mutations, and then they directly damage blood vessels due to ischemia. So because the radiations are external, the external surface, the conjunctiva, the cornea are usually affected. Occasionally, the lacrimal gland may be affected. The hallmark is that when you have a radiation, healing is poor, very poor. So punctate epithelial healing, punctate epithelial erosions that heal very, very badly. So the thing to do is to remove the patient from the radioactive substance. In mild cases, artificial tears, bandage contact lenses may be all that is needed. In severe cases, one can start thinking about tassuraphies, conjunctival flaps, autologous or from the same eye, amniotic membrane transplants, limbal stem transplants, or in severe cases where there's melting, and use a mucous membrane graft. Lots of problems. Wound healing is very poor. Decreased tear production, loss of corneal sensation, sloughing of the epithelium, failure of cornea to heal, that are so difficult to manage. Spiders, sting, chemosis, chronic stages, if they don't remove, they may have a localized granulomatous inflammatory response, which is called ophthalmia nodosum. The initial management is topical cycloplegia, steroids, occasionally even systemic if there's reaction all over the body, and topical antibiotics. If you can, you must remove the spikes. Very important. As soon as you remove the spikes, the patients are so grateful. Subconjunctival hemorrhages are common. Many of us have seen this in our clinics during our training. The important thing is to rule out damage to the deeper structures. And also runic disease, a Valsalva maneuver with trauma and just coincidence. And so you must rule that out. If it's just trauma, it resolves spontaneously in 2 weeks. Now, if you find a patient who has recurrent subconjunctival hemorrhage, you must start thinking, is it uncontrolled hypertension? Is it diabetics? Does this patient have systemic blood disorders, lymphangioma, amyloidosis? Or are they on medications like non-steroidal, anti-inflammatory drugs, antiplatelets, aspirin, anticoagulants, heparin or warfarin, or are they on thrombolytic medication? All of these cause bleeding, and you want to rule those things out. Patients may also have corneal epithelial abrasions. These are straightforward conditions. Patients present with pain, foreign body sensation, tearing, and discomfort when they blink. Remember that abrasions caused by fingernails and vegetable matters heal poorly, whereas those that are from things like steel, glass, they heal much faster. For corneal abrasions, the management is patching, but most of the time you don't really need to patch. I don't patch my abrasions most of the time. Bandage contact lenses, if you have to patch, is probably better because the patient allows them to see. Usually we give them cycloplegics and antibiotics. Now, to give or not to give non-steroidal anti-inflammatory topical medications, well, remember that they have local toxicities. They cause more ulcerations and they result in delay wound healing. So it's probably want to avoid those ones. Blunt injury causes traumatic anterior uveitis, usually within 72 hours after the injury, 48 to 72 hours. Typical anterior uveitis symptoms of circumciliary flush, photophobia, tearing, and pain. And the treatment is as you treat any uveitis with cycloplegia and steroids. Now you may have traumatic mydriasis. The pupils are dilated from trauma, usually because of the damage to the iris sphincters, they tear. And these are usually permanent changes. So you can give the patient sunglasses for the photophobia that they have. But if that doesn't work for the patient, then surgical correction may be the thing to do. And in this case, if it is a very large mydriasis, then you may want to put an artificial iris into the anterior chamber. If there are smaller lesions, then the mydriasis is treated, or an iris diaphragm contact lens can be placed on the cornea. You may also have a small pupil. Usually small pupils after trauma is due to the inflammation of the trauma, and regular steroids for the inflammation will resolve that issue. Now, if your iris separates from the ciliary body iridodialysis, then it depends. If it's a small iridodialysis, then no need to treat these patients because the patients become usually asymptomatic. Larger iridodialysis requires surgery because the patients have polychoria and monocular diplopia. And if you need to repair it, you must repair it quickly within a few weeks of the injury, because when you wait too long, then even when you repair the iridodialysis, the pupil still remains, it's not round, right? You may also have cyclodialysis, which you recognize when you do gonioscopy and you see a gap between the posterior edge and the scleral spur, and the sclera may even be visible on gonioscopy. Mild cyclodialysis requires topical cycloplegia. But if that is not enough, then lasers can be used, diathermy can be used, cryotherapy can be used, or direct suturing of the cyclodialysis cleft can be done. Now let's talk about hyphema, blood in the anterior chamber, usually young men who fight amongst themselves. And the bleeding may vary from very small microhyphema that you look at the slit number and see little blood vessels in the anterior chamber, few circulating blood cells, or you can actually see a layered the blood level as you see in this picture. You can even have a clot or a total filling of the anterior chamber. Total 8-ball hyphema fills the whole of the anterior chamber. Prognosis is usually good. Now, of course, if it is only the hyphema, isn't it? But usually, frequently, there's other ocular injuries. And so the prognosis depends on the other ocular injuries, not the hyphema itself. The hyphema will usually clear. Even a total 8-ball hyphema can be solved. Now, you need to rule out spontaneous hyphemas. Patients who have central retinal vein occlusion, diabetic retinopathy, with rubiosis iridis will bleed. Clotting abnormalities will bleed. Hepatic diseases, uveitis, glaucoma, hyphema syndrome, when you put a posterior, a single piece intraocular lens in the sulcus, the iris will chafe and will bleed. Juvenile xanthogranuloma, retinoblastoma, and leukemias in children. So always rule that one out. Don't assume that the hyphema is due to trauma. The issues with hyphema, there are three main issues. Rebleeding. Rebleeding will occur within 3 to 7 days, and that's the greatest concern after traumatic hyphema. And then raised intraocular pressure. 50% of hyphemas will have raised intraocular pressure that can lead to optic neuropathy. And then finally, staining of the cornea. And that's a bad thing. That would take months to years to resolve. So how do you manage traumatic hyphemas? Your aim is to minimize rebleeding, control the inflammation, and control the intraocular pressure. You want to give long-acting to improve the patient's comfort and to eliminate iris movements and to allow posterior segment evaluation. You want to give topical steroids, which also reduces the rebleed and controls the intraocular pressure. Aggressive management of intraocular pressure rise is needed in topical, oral, or even systemic if that needs to be done, and close observation of these patients. You may want to restrict physical activity of the patient, limit Valsalva-related activities like pushing and coughing, and then you want the patient to rest and raise their head up. Now, a very special condition, and for those of us in the West African and African sub-region, we see this a lot. Maybe, I don't know, perhaps a few in Ethiopia as well. Maybe rare in Asia, but sickle cell disease is very common among Blacks. And if they have hyphema, they need special consideration because the sickle cell, right, which appears not round but sickled in shape, cannot flow through the trabecular meshwork, and the pressures go up very high. The optic nerve is also at risk because there's a decreased blood flow to the optic nerve, and carbonic anhydrase inhibitors, osmotic agents, they reduce aqueous flow because they cause hemoconcentration and they make the sickling worse. So you want to avoid carbonic anhydrase inhibitors in sickling cell patients. And then in sickle cell patients, you want to intervene earlier than the average. If the IOP is 125 millimeters mercury, for 24 hours, you want to go in. Or if there's a repeated, even transient IOP rise, 30 millimeters of mercury for 2 to 5 days, you want to go in earlier. In general, for all hyphemas, you want to go surgical intervention when the intraocular pressure is more than 25 millimeters of mercury for more than 4 days with a total hyphema, or the intraocular pressure is more than 60 millimeters mercury for 2 days. If you have any sign of corneal staining, so you need to constantly look at the cornea, you want to remove the blood. If there's pre-existing optic nerve damage or pre-existing hemoglobinopathies like the sickle cell SC disease, you want to intervene early. How do you do that? Just simple AC irrigation through a side port limbal paracentesis. You don't need to remove the clot. So far as the visual axis is free, that should be enough. If you try to remove too much clot, you may have a secondary bleed. Now, residents need to understand the difference between a penetrating and a perforating ocular trauma. Examples are given in your textbooks and you can refer to them. Penetrating wound, the foreign body passes into a structure and remains in the structure. A perforating wound, the foreign body passes through the structure. So you can have a penetrating wound of the cornea or a perforating wound of the cornea, and that perforating wound of the cornea will be a penetrating wound of the globe. So if you have a conjunctival laceration. These are simple, straightforward trauma. All you need to do is to ensure that the deeper structures, the sclera, is not damaged, and that there are no foreign bodies underneath the sclera. So that needs some exploration. In general, small corneal lacerations do not need to be sutured. If there's a stellate laceration or a laceration with a bare sclera, you may put in absorbable sutures, 1 or 2, to close it. For corneal foreign bodies, it's important to rule out any intraocular foreign body that has been missed. But be careful, if vegetable, organic matters, fungal keratitis, so you pay attention to those patients. If there's a glass foreign body, you can remove it. Any foreign body should be removed. If glass is deeply embedded, you can leave it alone. I have patients who have glass in their corneas for 15 years and they are fine, right? Especially if the visual axis is free. Careful gonioscopy may be important to rule out foreign bodies in the angles. An iron foreign body for 24 hours on the cornea will form a rust ring, which you can easily remove with a hypodermic needle. Some people use a dental burr to remove it, but that causes excessive tissue destruction and increases the scar formation. During your evaluation of any ocular injury, you must examine the pupils, look for afferent pupillary defect, abnormalities of the pupils, and you must also rule out any systemic injuries that are life-threatening. But also you must avoid any procedure that causes pressure on the globe, like gonioscopy, force duction test, and so on. Avoid all of those things, right? So management, if there's just minimal perforation, non-surgical management, minimal perforations can heal spontaneously. We've seen many of those. The anterior chamber is deep, antibiotics, close observation is all you need to do. If there's a small perforation, it's not gaping, the sidal test is positive, and the anterior chamber is deep, then you may just use pharmacological acute suppressants, topical or systemic. You can patch the eye, or you can put a therapeutic bandage contact lens. Or if it's very large, or it's very extensive, you can try a tissue adhesive. If the sidal is positive and the anterior chamber is flat, then you should go in and repair that, because anterior chamber is flat means that the anterior chamber cannot be sustained. You need to go in. If the sidal is positive and the anterior chamber is formed and you use the pharmacological patching and therapeutic contact lens, and still after 2 days it fails, then you need to go in and suture the defect. The surgical management, the principle is to restore the globe, reduce damage to intraocular structures, minimize inflammation, and reduce endophthalmitis. So keep all this in your mind whilst you are doing it. Before the surgery, apply a protective shield while the patient is going through the recovery ward and the outpatient department, and you yourself avoid excessive manipulation. Anesthesia, it's recommended that you use general anesthesia if there's for repair of an open globe, because the injections can put pressure on the globe and make things worse. All right. Now, if the patients have other conditions requiring surgery, non-life-threatening, non-emergency surgery, delayed globe, you do the corneal laceration before you do other life-threatening surgical problems, because the preparation of the patient for surgery can damage the open globe. You also do your corneal repair before you do any lid or orbit repairs, because doing orbit repairs and lid repairs can make the globe worse. So keep that in mind. Non-life-threatening surgical problems after the corneal repair, agnesia, lid repairs after the corneal repair. Now, these are the steps, and I'm not going to go through. There are a lot of videos that shows the surgical steps in repairing corneal wounds, 11 main steps, and please familiarize yourself, watch the YouTube videos, and know how these things are performed. A few good diagrams on how to remove incarcerated intraocular foreign bodies, iris, vitreous, and so on, and the various surgical techniques. And please watch these videos and how to. There are various techniques. If you follow your consultants and your teachers, they'll show you how to go through this repair properly. But then these are some very good techniques that you can use that increases the outcomes and reduces complications. So we'll go on, and I encourage you to watch videos on how to repair these things. You understand them best when you watch these videos and you observe them in theater rather than read a long descriptive list of things to do. For me, I don't get it. I need to watch a video and then I need to watch someone else do it. Then it's better for me. And I would recommend you do that. But the post-op management, you need to prevent infection, you need to suppress inflammation, you need to control the intraocular pressure, which is going to rise in some cases, and you need to do things. Pain relief can be done by cycloplegia and steroids. A few issues with corneal repair: the intraocular pressure may rise or may be low. If there is low intraocular pressure, post-operative hypotony, then look for a wound leak, perhaps in the orbit. Cyclodialysis cleft can cause a poor hypotony, ciliary body shut down because of trauma and inflammation, or a choroidal effusion. There could also be hemorrhage, intraocular hemorrhage, that can also cause the pressure to rise, but in itself can poor outcomes. In children, you need to suture, the sutures can be removed early as 6 to 8 weeks. And generally in wounds that are on the limbus heal faster. So that should guide you in which sutures you should remove. You don't want to be in a hurry to remove the central sutures. You rather want to remove the limbal sutures further. Special considerations in children. Amblyopia is an issue. So vision correction should start early. Indeed, even in adults, you want to start vision correction early, but in children, much early. And the uninvolved eye in children should be patched quickly, perhaps even the first day post-op, letting the other eye to see. Once the wound has healed and amblyopia has been managed and the visual axis is clear, a rigid contact lens, permeable contact lens, can create a nice, lovely surface that may improve the vision a little bit. So that's it for corneal trauma and injuries. Now we'll talk about transplants, corneal transplantation, the tissues. Now, we in the United States, I've used Optisol, and Optisol is what I've used over the years. Usually in the United States and other areas, they typically present the tissues in Optisol or like 4 degrees centigrade. Now, these contain antibiotics, gentamicin and streptomycin infused into chondroitin sulfate and dextrine. Like 4 degrees centigrade also contains insulin. And these tissues can be stored at 2 to 8 degrees. So you need a cold chain. You don't let the tissues, you don't lose your cold chain. And they can be viable if you keep your cold chain for up to 2 weeks. In Europe, however, they have a different technique. They use tissue in an organ culture, and they store it at 37 degrees centigrade. I haven't used these type of tissues before. These allow the tissues to be stored for a very long time, 35 days. So really, it's very ideal for long-term usage in areas where there are issues. But the process is more complex, it's costly, it's labor-intensive, and the costs are high. So there are two types, but not every tissue can be used. These tissues are assessed if the patient died of unknown cause, unknown central nervous disease causes. They have CJ disease, they have septicemia, they have hypertension, hepatitis B, syphilis, rabies, retinoblastomas. These are excluded. So there are protocols that they follow to exclude these. So they are not used, these are bad tissues. Now, when they are selected, we want good quality tissues. A good quality tissue, a good quality graft is one that has an endothelial count that is more than 2,000 cells per millimeter squared. If it's less, they can be used for drug. And patients who have been dead for 12 to 24 hours, well preserved. And then donors who are aged between 2 years and 70 years can be used. Now, some people have been used tissues more than 70 years, even 80 years. Now, patients for DMEC, 50 years and below is recommended because tissues membranes that are older than 50 years are more difficult to control. The reason why we don't use tissues younger than 2 years, 24 months, is because these are extremely steep and difficult to handle, challenging to create a watertight, closure and predict and achieving a good refractive outcome. So there are many types of corneal transplant. The main ones are penetrating keratoplasty, which is a full thickness. Many of you know this already. Anterior lamellar keratoplasty, where part of the anterior lamella is done, is transplanted. Deep anterior lamellar keratoplasty, where the whole of the stroma down to the decimate membrane is dissected down to the decimate membrane. This done with air bubble, viscoelastic, or manually, and you eliminate endothelial rejection. And then there's DSEC and DMEC. DSEC means decimate stripping automated endothelial keratoplasty. DMEC means decimate membrane endothelial keratoplasty. There are a few others which I've left out. So this list is not exhaustive. So there are some more. But these are the main ones which I'm going to talk about. In DMEC and DSEC, only the endothelium is moved, and the recovery is faster, more predictable refractive outcomes, reduced risk of endothelial rejection compared to PKP, and there's no or minimal surgical induced astigmatism. So I'm going to talk a little bit about PKP. The indications are mainly if you have pathologies involving the stroma and endothelium. But indeed, any kind of corneal pathology used to be done with PKPs and quite a good success rate. So if you keratoconus, you do PKP, but of course you prefer DOLC. And graft failures, endothelial keratoplasty is preferable, but you can still do PKP. And corneal opacities, congenital opacities, chemical bends, PKPs are good. Again, watch videos on PKPs. So I'm not going to go into the surgical technique into details, but remember that you must cut the donor tissue first before you cut the host. Otherwise, you have a cooking style for a very long time. And if you have a squeezing patient, you've had it. So you prepare the donor first, make sure it's nice and good, and you're happy with it, and then you come and then you prepare the host. Usually you want to cut the donor a little bit bigger, about half to a quarter millimeters larger than the host. That reduces the risk of post-op glaucoma. It enhances, make sure you have a watertight wound, prevents peripheral anterior cyanicae, and then you have a lot more endothelial cells for you to, except in keratoconus. In keratoconus, we want to flatten a steep cornea, and so a graft hosts that are equal in size will ensure a flatter cornea than the patient came with. All right. The suture techniques, again, I'm not going to go into details, but a few critical points. Watch the videos. You want to secure with 4 interrupted cardinal sutures. The first suture, you stick it on wherever you want to, 6 o'clock maybe. But the second suture is the most important. It has to be directly opposite, 180 degrees opposite side. So most people do 6 o'clock and 12 o'clock, exactly opposite, because your astigmatism is dependent on that second suture. The second suture is the most important one. Then you can continue with interrupted sutures or continuous sutures, or do both interrupted and continuous combined after being 4 interrupted sutures. Partial thickness sutures are taken 90% depth. And for children, we prefer doing interrupted sutures. After surgery, post-op, the standard steroids, antibiotics are given to these patients, and frequent reviews are important. You may find out that the tissues just fail, called primary donor failure, bad tissues, perhaps due to handling or breaking of the cold chain. And here you see that the graft is edematous on day 1, and there's not much inflammation in the patient's anterior chamber. So in such cases, you want to allow 4 weeks, maybe 2 months, and see if there will be spontaneous resolution before you go in and regraft. In quite a few instances, when they have primary graft failures, the host endothelium may compensate, and the cord tissues may clear up. So you want to wait a little bit. Now, the intraocular pressure rise is a very thing. It occurs a lot, and many cornea surgeons have to contend with this. In the early postoperative period, it may be due to pupillary block, arterial misdirection, bleeding into the trabecular meshwork, or too tight sutures. If they occur within 1 month, it's usually the steroids. And they occur months, years later, it may still be due to the steroids, but also look out for epithelial downgrowth and a fibrous ingrowth. Please read the differences between epithelial downgrowth and a fibrous ingrowth. You may also have recurrence of the primary disease in the graft. Fungal infections, bacterial infections, viral amoebic keratitis can just recur in the graft. Usually, these occur within the early post-operative period. But the corneal dystrophy can also recur after a year or more. Epithelial stromal dystrophies, such as granular dystrophies, lattice dystrophies, can recur in the graft. Now, your sutures. Plenty of problems with your sutures, and you need to pay attention to your sutures. You can have excessive tightening, loosening of your sutures, broken sutures, suture abscess, suture infiltrates, giant tail, conjunctivitis, inflammatory, allergic reaction from exposed sutures, vascularization of the sutures. Every clinic time you must examine each of those 16 sutures if interrupted. If it's a corneal sutures, if it's a continuous suture, you have to look all the way around and manage the suture-related problems as they come along. Now, you may have microbial keratitis occurring in the tissues, the graft, because you're using a lot of steroids. And so the immune reaction to fight against microbial infection is reduced. And then also you have reduced corneal sensation after transplant, and then even tear film, and then suture-related issues. The patient may be on systemic immunosuppression. All of this increases the risk of microbial keratitis. You want to do a culture and sensitivity of the infiltrates, and then before the culture and sensitivity results come in, you want to start broad-spectrum antibiotics. Now, there's a special type of microbial keratitis called infectious crystalline keratopathy that you have to look out for. It's not very common, but look out for them. And occasionally it is observed in grafts. And these are branching colonies of organisms that proliferate in the deep corneal stroma. There's minimal or no inflammatory response, as you would observe in other bacterial keratitis. And many organisms have been implicated, but currently we think Streptococci viridans are the most frequent causative organisms. Now, there's a many years endothelial failure, which is non-immune. Now, that is a result of normal attrition of endothelial cells that occur amongst all of us. But among transplanted patients, this occurs 4 times faster than in a non-transplanted cornea. So soon, that's why you need to have a high count to start with, more than 2,000. Otherwise, eventually down the line, you are going to have a non-immune endothelial, just normal decline, which is faster than in non-transplant patients, and your transplant is going to fail. Glaucoma patients especially are at risk. Patients who have a history of glaucoma, patients who have had tube surgeries done are at higher risk of having such a problem. Now we'll talk about graft rejection. Normally, graft rejection, immune-related graft rejection will not occur within the first month. They will occur many months later, or weeks later, or many years later. Need to recognize graft rejection early, promptly, and treat them urgently. Patients will complain of pain, redness, photophobia, and decreased vision. You have to tell your patients to look out for this and report immediately when they have signs of these things coming. There are 4 distinct clinical forms of graft rejection. There's epithelial graft, subepithelial graft, stromal graft, and endothelial graft. You need to recognize all of these. Epithelial rejection is an elevated linear epithelial ridge, as you can see in the picture here, that advances centripetally, meaning from the periphery, from the edges, and moves centrally. No, it's not a big problem because the donor epithelium will eventually, ultimately replace the host epithelium that is rejected, and everything clear. But it is an indication, it may be an indication of an onset of an endothelial rejection, which is a more serious issue. So if you recognize it, look carefully, pay attention, and be prepared of a possible endothelial rejection. It may be symptomatic, you may have a blurred vision, especially if it is the ridge is in the visual axis. And then you have subepithelial rejection, a rejection which may be asymptomatic, may cause a glare and reduced vision. It's easily missed if you don't examine carefully, and it may resolve completely if treated. But of course, like I said, for epithelial rejection, it may be a sign that there may also be an endothelial graft rejection, which is a more serious matter. Now, stromal rejection, most of the time you have it commonly in dog. They have stromal infiltrates, neovascularization, non-infiltrative keratolysis within the graft host interface. The cornea may become necrotic if it's severe and prolonged, and it may be accompanied or followed by endothelial rejection. And the treatment is in a similar way. Now, endothelial rejection is the most common and the most serious of all the rejections. There's the typical Kwadwo's line, which are inflammatory precipitates, and you have KPs. There's an inflammatory line that proceeds, and there's anterior chamber reaction, and the uveitis may be mild. There's stromal thickening, folds, subepithelial bully, and patients complain of photophobia, redness, irritation, and blurred vision. So you must tell the patients they should come back to you anytime they have any of these things. The treatment of rejection is steroid, must be aggressive. Steroids, monitor the intraocular pressure. If the patients are steroid responders, you can give them tacrolimus ointment. It's said to be more effective than topical cyclosporine. If it's aggressive, serious, you can give oral or IV steroids. Must be aggressive, right? If the patient has active hepatic keratitis, then you want to replace the oral steroids. You want to replace topical with oral steroids. The key is be aggressive as you want to arrest the rejection. Now, post-op management of astigmatism, the sutures that we place in causes a considerable amount of astigmatism, and that has to be managed actively.
So I'm going to deal with the chapters 13 and 14. I'm Dr. Amoah. I'm a cornea specialist in Ghana. So I'll start with chapter 13, which is on diagnosis and management of immune-related disorders of the external eye, the cornea, and the conjunctiva. Essentially, we are going to talk about disorders of immune derangement, when the immune system now begins to misbehave, to put it in a layman's language. Its manifestation as far as external eye, the cornea and the conjunctiva are concerned. I must disclose that most of the material are sourced from the Basic Clinical Science series by the American Academy of Ophthalmology. And some of these slides are already in circulation. So we quickly want to look at allergies. Allergies of the external eye. We have an entity called a contact dermatoblepharitis. And it's simply an allergic reaction to a topical or an environmental allergen. And it has this unique presentation where you have a patient gives a history of having used a cycloplegic agent. Atropine is the typical culprit, or having used an aminoglycoside like gentamicin or an antiviral agent, or any of the preservatives or some of the topical agent, and they come within a very short period of time with late edema, with signs of type 1 hypersensitivity reaction. So typically, it's a type 1 hypersensitivity reaction, which is mediated by IgE elaboration by mast cells. So the typical clinical features are itching, you have erythema, edema, hyperemia, and the chemosis. Then we have the delayed entity, which occurs after 24 to 48 hours. And that is characterized by leathering and scaling of the eyelids. The treatment is basically supportive, and then discontinuation of the inciting agent. So what is determined to be the allergen has to be discontinued. Then we have atopy, the variant that takes the form of atopic dermatitis. That one is underpinned by a type 4 hypersensitivity, cell-mediated hypersensitivity reaction. And then you have increased levels of IgE and histamine, and then mast cell degranulation associated with that. So they have these associations: asthma, history of asthma, allergic rhinitis, nasal polyps, eczema, and other forms of atopy. Clinically, you have periorbital darkening, exaggerated eyelid folds, ectropion that is in the extreme forms. When you have extreme response, you have entropion, then you have signs of conjunctivitis, as you can see in this picture. The treatment is moisturization and application of steroids. Then we have the acute allergic forms. We have hay fever conjunctivitis, which is often seasonal, as the name indicates. It's a type 1 sensitivity, hypersensitivity, type 1 hypersensitivity mediated, and therefore you have elevated levels of IgE. It often tends to be associated with allergic rhinitis and asthma. You have itchy eyes, eyelid swelling, hyperemia, chemosis, and then mucoid discharge. And this is quite typical of most of the allergic eye diseases. Again, the treatment is supportive. In the acute phase, cold compresses tend to help a lot. Then artificial tears for the purpose of diluting the mediators of inflammation on the ocular surface. Then topical antihistamines, mast cell stabilizers, NSAIDs, topical NSAIDs are found use low potent corticosteroids, vasoconstrictors, and then systemic antihistamines for situations that do not respond well to the topical medications. The almighty venal keratoconus
Dr. Amoah, we're losing you. Dr. Amoah, your connection.
Those of us in the tropics, this is quite common. Is it better now?
Yes.
Please,
yes.
is it better?
Yes. Now it's come back. Thank you, Dr. Amoah.
Good. So it's quite common in the warm zones of the globe. Tropical Africa, tropical Asia. It often presents as a bilateral affectation of the eyes. It has male preponderance, you have involvement of the upper lid tarsal conjunctiva. It's underlined by type 1, and some authorities say there is a component of type 4 hypersensitivity reaction as well. So you have the typical signs of allergy. You have itching, blepharospasms, photophobia in very severe situations, blurry vision, then ropey, copious mucoid discharge. On examination, we find diffuse papillary hypertrophy and sometimes ecchymosis and giant papillae, as you can see in this picture. Then we have types that also tend to be predominantly affecting the limbus. That is the limbo type, and that tends to be characterized by thick gelatinous corner trunca dots that are aggregates of eosinophils and epithelium. Now, one of the common sequelae of this type is panels formation in the medium to the long term because of the recurrent inflammation involving the lumbar conjunctiva. And that tends to set the stage for a form of lumbar stem cell deficiency. Now, the palpebral type, which is characterized by very giant papillae, tends to be associated with what we call shield ulcers. These are areas of cornea epithelial instability and sloughing as a result of the unfriendly composition of tear because of the disease. You have increased levels of proteolytic enzymes. And then with the least trauma, the microtrauma from the giant papillae lead to sloughing of the cornea epithelium, which is already unstable, and then you have ulceration. The treatment is with topical antihistamine, mast cell stabilizers, corticosteroids, and for refractory cases, we have to use cyclosporins and tacrolimus. This shows the lumbar type with corner trunca dots, and then this is a shield ulcer. A slough, an area of epithelial, loss of epithelium because of the instability of the epithelium from the altered tear composition, and the microtrauma from the giant papillae. Then there's another entity which tends to present quite late. The onset is quite late in life. The atopic form, atopic, because it tends to be associated with atopy. So you have association with atopic dermatitis. It occurs all year round. It's underlined by type 4 hypersensitivity reaction. So you have papillae on the upper and then the lower, upper and lower conjunctiva. You have cornea edema. You have subepithelial fibrosis, particularly around the peripheral cornea. And this tends to be associated with vascularization. This is quite typical, and the pictures will show. So this picture shows an eye that has atopic keratoconjunctivitis. You can see the peripheral cornea is highly vascularized. It has some amount of opacification, and you can see the edema of the lumbar conjunctiva. So the supportive measures are application of cold compresses. Of course, you have to avoid the allergen, and then unresponsive cases can even progress to give a scenario of a PUK, and then One unique feature of atopic keratoconjunctivitis is cicatrization. It tends to be associated with severe scarring and panels formation around the limbus, and sometimes it infiltrates to involve a significant portion of the paracentral cornea. And for such instances, for cases that are unresponsive to mild measures, non-invasive measures, we have to be quite aggressive and even initiate systemic immunosuppressive therapy in order to preserve the cornea. Right. It's important residents get to know the differences. Epidemiologically, in terms of age, vena keratoconjunctivitis has an earlier onset. The onset is earlier than atopic keratoconjunctivitis. Vena keratoconjunctivitis tend to have a mere preponderance. In terms of the pattern and the seasonality, vena keratoconjunctivitis is seasonal, but atopic is all year round. As I've said, VKC is common in young males. Atopic keratoconjunctivitis has a late onset in older people. This tends to be characterized by giant papillae in many people. Then you have small, medium-sized papillae in atopic keratoconjunctivitis. This tends to be, in most instances, limited to the upper lid. You have both upper and lower lid involvement. You have cicatrization, scarring of both the forbibula and then both the forbibula and the bulbar conjunctiva with neovascularization, which is panels formation. Now, we look at ligneous conjunctivitis. This form of chronic conjunctivitis occurs as a result of a genetic defect. And the genetic defect is that there is an inherited deficiency in type 1 plasminogen. So there is hypofibrinolysis. And you have woody yellow pseudomembranes bilaterally involving the conjunctiva. And these pseudomembranes consist of fibrin-bound tissue, plasminogen activator, epithelial cells, and then inflammatory debris. And the symptoms are intense irritation and foreign body sensation. And it's always important, this can mimic an infectious process, and therefore it's always important to rule out infection, particularly granulomatous infection of the conjunctiva. The treatment consists of excision with or without cryotherapy, but recurrence is quite frequent. Trial of heparin and steroids have been recommended, though have not always proven effective, and many resolve spontaneously after several months to years. So this is the ligneous, the focus, the pseudomembrane that often is seen in this condition. Quite a thick one, and it's a composition of all these, the list here. The next, it's almighty Stevens-Johnson syndrome. I want to pose a question. Stevens-Johnson syndrome and then TEN. Is there any difference? Who want to answer this? And if there's any difference,
In cases of SJS and TN, the body surface area is different. In cases of TN, the body surface area involved is more than 30%, and in cases of SJS, the body surface area involved is less than 10%.
Great. Who is that?
It's me, Dr. Nistal from Tilganga.
Wonderful, wonderful. So we have these subtypes, right? It's almost the same presentation, but depending on the involvement, the amount of skin involvement, we're able to classify them into 3 clinical entities. SJS, that is when you have the skin lesions with up to 10% skin involvement. Then you have the overlap presentation. The overlap disease is when you have SJS plus SJS stroke TN overlap. That is when you have the skin involvement up to 30%. Then it's solely TN when the skin involvement is 30% or more. Right. So it's very, very important to keep this in mind, the classification. The cause, I don't need to elaborate it. That is a type 4 hypersensitivity reaction to drugs and to some infectious agents. And it's quite frequent in women than in men. Clinically, you have fever, arthralgia, malaise, target lesions. The target lesions are you have a central spot with a pale ring followed by a reddish ring. That is the target lesion. Then the ocular manifestations, you have pupillary discharge and signs of conjunctivitis. You have episcleritis, episcleral involvement. It tends to be associated with, in the medium to long term, with scarring. Then eyelid margin characterization, the lid becomes keratinized, and that is a very poor prognostic factor in the long term. Now, because both the conjunctiva and the corneal epithelium become unstable in this condition, they are at very high risk. Not only that, even the skin are very high risk of infections. And the treatment involves stopping the offending agents, the use of steroids, both systemic and topical, is quite debatable. Some authorities advocate for it, others are against it. The use of intravenous immunoglobulin, the same. But hydration is very, very important because of the body surface area involvement. The ocular measures by way of treatment, glass rod for the purpose of preventing symblepharon appears controversial. It used to be an old practice, but most current literature don't seem to be in support. The reason being that much as, yes, it sounds so reasonable that by rubbing, you may break any forming adhesions. As you rub, you cause more surface abrasions, and that may worsen the inflammatory process. So it's quite controversial, the role of rubbing. It has worked in some instances, it hasn't worked in some instances. Lubrication is a must, intensive lubrication. Topical antibiotic prophylaxis, and then steroid use. Amniotic membrane transplantation, very, very useful, and that is accepted by many authorities. The reason being that amniotic membrane has a lot of growth factors that can enhance surface reepithelialization and also has anti-inflammatory agents that can combat the intense inflammation that tends to be associated with this disease. The sequelae, because it ultimately leads to surface cicatrization, you have entropion trichosis. One of the means to correct this is MMG, mucous membrane grafting. And it's not only to correct the lid abnormalities, but also to reconstruct the late margin when you have late margin keratinization. As I said, late margin keratinization is a very poor prognostic factor. So we do the MMG to correct that. Then the wearing of scleral contact lenses. We have the PROS lens. The PROS lens has found a place in the management of Stevens-Johnson syndrome. I don't know if anybody has an idea about the PROS lens. What is the PROS lens? Just the basic description. Who can describe what the PROS lens is? Any volunteer?
PROS lens is a prosthetic replacement of ocular surface ecosystem.
Good. And how is it designed? How is it designed?
It's a kind of a scleral lens.
It's a scleral lens, but it has a normal solar reservoir. And the theory behind that is that as it's worn, the normal solar reservoir tends to serve as a conduit for the elimination of toxic material, accumulation of, inflammatory debris from the ocular surface. And that in the long term leads to healing and reconstruction, rehabilitation of the ocular surface. In situations where all measures fail and you have severe cicatrization, you have dermalization of the cornea, then the only way out for restoration of vision is doing keratoprosthesis. That is in situations where ocular surface lubrication is fair. It's fair to good. If you do K-Pro and ocular surface, lubrication is bad, it still may not work in the long term. Now, a cousin, I'll call it a cousin of SJS, is mucous membrane pemphigoid. It used to be called OCP, ocular cicatricial pemphigoid, but we have deemed it necessary to change the name to mucous membrane pemphigoid. Why? Why is it? It used to be ocular cicatricial pemphigoid, but why the change in name? It has a reason. What qualifies to be called a mucous membrane pemphigoid? It's not only about the eye, but the other entities. Who can tell me?
It has changes in other mucous membrane like oral and also anal areas also.
Great. So before you can have the mucous membrane pemphigoid, yes, you need ocular surface cicatrization as we see, but you also need the involvement of at least two other mucosal surfaces. It could be the oropharynx, it could be the mucous mucosa, it could be the inner mucosa. So that is, and almost invariably, you tend to have this. So in situations where you have only ocular surface cicatrization, yes, you'll be right to call it ocular cicatricial pemphigoid. But if you are meticulous in your examination, you almost invariably detect that there will be the involvement of other mucosal surfaces, at least two or more. That is the reason. Now, it's common among women than men, and usually after the fifth decade of men, after the fifth decade of life, the women who are predisposed tend to have it. The staging helps us to determine the line of treatment, the measures to be taken. But basically, you have to diagnose it, and we diagnose it by taking conjunctival biopsy. It's very, very important to observe this, that in taking the biopsy, we take the biopsy at the junction between the healthy area of the conjunctiva and the disease area. And when you subject the biopsy is preserved in liquid nitrogen, and then we subject it to direct immunofluorescence. And you are supposed to find This complements IgG, IgM, and IgA that are bound to the basement membrane of the conjunctiva. So depending on the stage, for mild conditions, we treat with dapsone. For very severe forms, we use immunosuppressants, cyclophosphamide and corticosteroids. And for very severe disease, we give IV immunoglobulins and biologics. So we stage, and based on the stage, we initiate the appropriate line of treatment. Surgical intervention is mainly for symblepharon release, and it tends to be bilateral. So if you have a disease that is affecting the cicatrizing condition that is affecting both conjunctiva, what are the options? The options for symblepharon release. Any volunteer? You have a condition that has called conjunctival scarring in both eyes. You have severe symblepharon, but there's visual potential. You want to release the symblepharon. What are your options?
We can do symblepharon release with amniotic membrane graft.
Good. Or assuming you don't have access to amniotic membrane.
Can they become mucosal grafts?
Great. Wonderful. Who was that?
It's me, Alex Ado, from Kolebu.
Right. So you have the option of AMG or MMG. Great. So we move on to graft versus host disease. Normally, the host immune system that rejects a graft, but you can have a situation, particularly in hematologic conditions, hematopoietic conditions, where the grafted tissue now begins to cause trouble, cause derangement. Right, and that is what we call the graft versus host disease. The grafted tissue now begins to attack the host, and this happens very frequently in bone marrow transplant. So clinically, you find conjunctivitis, scarring changes, cornea scarring with limbal stem cell deficiency. The treatment involves lubrication, punctal occlusion, the use of immunosuppressant, therapeutic contact lens, and then acetylcysteine. And then severe immunosuppression for very exaggerated forms. They tend to be associated with subcapsular cataract. So this picture shows that these are very thick filaments. It's all because of the attack on the ocular surface, the conjunctiva and the cornea epithelium. Tigersons. Tigersons presents as pain out of proportion to what we find clinically. It is very recurrent. The patient complains of foreign body sensation, photophobia, reduced vision because of altered cornea surface. How does it present? On examination, you find multiple slightly elevated cornea epithelial lesions with negative staining during exacerbations. Then these areas of elevation are round, over gray granular cramp-like opacities with minimal injection. The conjunctival involvement is very, very minimal. That is what differentiates this from other forms of epitheliopathy. The conjunctiva, you see the cornea is quite unhealthy. The cornea is not well, but the conjunctiva is hard, it's quiet. Right. Its response to low-dose topical steroids, artificial tears, and sometimes cyclosporine. So you can see this. You can see you have, punctate lesions in the center of the cornea, both the stained one and the unstained. Interstitial keratitis. I want you to be familiar with this acronym, the causes. Tic-tacs, tuberculosis, inherited syphilis, trypanosomiasis, acquired syphilis, Cogan syndrome, and then sarcoidosis. Tic-tacs. These are the common causes of interstitial keratitis. Not forgetting the viral agents, VZV and HSV. They can all cause interstitial keratitis, but it's mainly a type 4 hypersensitivity reaction. And the commonest causative agent is syphilis. There's an entity called the Cogan syndrome, where in addition to the ocular affectation, you have vertigo, you have hearing loss in a young adult who gives a history of urinary tract infection 1 to 2 weeks prior to the stroma keratitis. So it presents as faint black subepithelial infiltrates. I have the picture here in the peripheral cornea, as you can see in this picture. Then you have nodular infiltrates in the posterior cornea. It's always important to rule out syphilis, and the treatment is with topical steroids. Reactive arthritis. This is an HLA B27 associated non-gonococcal urethritis induced, joint inflammation with this associated ocular manifestations. So you have papillary conjunctivitis, episcleritis, iridocyclitis, and then keratitis, urethritis, and then the arthritis. It is self-limited. It lasts 2 to several months, but it recurs. The treatment is supportive, topical steroids, and then systemic steroids. Peripheral ulcerative keratitis. So class, I want you to follow with a lot of attention. Right, so PUK has associations. You have rheumatoid arthritis or an immune-mediated condition like granulomatous with polyangiitis, SLE, PAN, ulcerative colitis, relapsing polychondritis, rosacea. All these are, autoimmune diseases. Then it may be associated with peripheral keratitis. It has 50% mortality within 10 years, and it correlates with exacerbation of systemic disease. The severity of the systemic disease tells how the patient is either well or poorly managed, and that tells on the clinical presentation you find. So you find keratolysis, you have rapid stroma melting. This appears within 2 millimeters of the limbus and have visceral occlusion of the limbal vascular network. You have usually unilateral and sectoral. The epithelium is absent. There's epithelia, the surrounding epithelium is quite unstable. The stroma is thin and tends to be painful. It's associated with both cornea and sclera involvement, unlike Morins. So the treatment involves resection. You move the limbal conjunctiva, which is the source of the inflammation, lubrication, banded contact lens, and then immunosuppression. Tetracyclines also have a role. And this picture shows that. So you have both sclera and cornea, marginal cornea involvement. Now, Morins ulcer. The difference between PUK and Morins is that Morins is of unknown etiology, but it may be triggered by trauma, surgery. There have been publications that link Morins to parasitic infection, particularly in African populations. The role of hepatitis B is debatable. It has been debated by some authorities. This is close to the limbus, and then resection of the conjunctiva tends to be therapeutic. So you have peripheral cornea ulceration, which spreads circumferentially. There is a lot of pain. The eye is inflamed. It's prone to perforation and secondary infections. Then eventually you have fibrosis and vascularization. The treatment, it has surgical and medical, intensive topical steroids. You may even have to add systemic steroids and sometimes immunosuppressants, lubrication to dilute inflammatory mediators. And then surgically, for cases that are close to perforation, you may want to apply tissue adhesives and bandage contact lens. Episcleritis, common in women between 20 and 50 years, presents as a red irritated pain, tender in exposed interpalpebral zone. It's not as painful as scleritis, blanches with epinephrine. So we have various types based on clinical presentation. You have the simple type, then we have the nodular type. It's generally self-limiting, and rarely do they need any systemic workup and intensive treatment with anti-inflammatory agents. Scleritis, as we know, it's a serious condition. It's associated with vasculitis, autoimmune diseases, connective tissue disease, and then immune complex mediated conditions. Common among women, the findings, you may have a piercing pain, wet at night, referred pain, then you have violaceous hue seen in natural sunlight, you have inflamed vessel that cannot be moved with a tip, with Q-tip, then you have scleral edema. These are the various clinical types, and then the treatment will involve elaborate systemic workup to identify any autoimmune disease, and then you tailor your treatment as you find on investigation combined with the clinical presentation. Great. I want you to be familiar with these immunomodulatory drugs, the various classes and the various types. Now, I quickly want to talk about the neoplastic disorders of the cornea and the conjunctiva, which is chapter 14. It's important to know that ocular surface tumors of the conjunctiva and the cornea are considered together because you can have one lesion affecting the contiguous tissue, or you can have the lesion affecting both tissues at the same time. And they are classified based on the predominant cell type. So we have epithelial lesions, we have melanocytes and nevus, we have vascular endothelial lesions, lesions that originate from mesenchymal cells, and then the lymphocytes. They are associated with a spectrum of conditions from benign to malignant, to pre-malignant to malignant. That is based on the clinical presentation and then histologic features. As a result, histologic examination is needed almost all the time for definitive diagnosis. The most common among the lot, malignant melanoma, squamous cell carcinoma, and then lymphoma of the conjunctiva. The clinical evaluation entails history, detailed history, and the focus should be on sun exposure, prior skin cancer, immunosuppression, changes in the lesion, the appearance of the lesion, racial or ethnic background. Then we size the lesion in terms of clock hours. It may be single or multiple, it may be pigmented or melanolytic. It may be located in the bulbar area or the palpebral conjunctiva or limbus or fornix. Then you also have to examine for extensions and palpate the lymph nodes. The lesions may be solid or cystic, flat or elevated, mobile or fixed. The vascularity, internal vascularity may be increased, which may be associated with increased external vascularity, which will manifest as feeder vessels. And we need detailed drawing or photos to monitor them. The management of options range from observation in situations where the diagnosis is not clear, or benign lesions that have benign features. And even in such instances, your suspicion for malignant transformation should be high. And that these situations, when the lesion becomes enlarged, when there's increase in size, when the lesion, which was otherwise, which was before proud, flat, becomes elevated, when there's extensive pigmentation, when there's a fixation to the underlying tissues, and then when you have prominent feeder vessels. Then we have the surgical option of management, where we perform a complete excision with 2 to 4 millimeter clear margin, and then it's preferred to use a non-touch technique for the purpose of avoiding tumor seedling, and then administration of double freeze-thaw cryotherapy to the healthy margins, and then application of absolute alcohol for the purpose of taking care of any malignant cell that might have escaped all these earlier measures. Then topical chemotherapy also has a role. The use of interferon, alpha-2b, 5-fluorouracil, and mitomycin. And then there are other treatment options on the horizon, including radiotherapy, and then the use of biologics. Great. So this shows the various options and the details, what to do for each entity. I will leave you to go through. So we can talk about the various entities now. Tumors of epithelial origin, the benign ones. We have papilloma, which tends to be associated with HPV 6, 11, and 16. You have the pediculated exotypic type, as you can see here. Then we have the sessile type. Right, the management involves excision, cryotherapy, then adjunctive interferon. It has a very high recurrence, so you must take note of that. Very high recurrence. Now, there's this new term. I would say new because it's founded on this. Ocular surface squamous neoplasia. This is a generic term that refers to a wide spectrum of conjunctiva and cornea squamous tissue that may have similar clinical findings but require biopsy for differentiation. So the traditional categorization of OSSN lesions as conjunctiva or cornea, intraepithelial neoplasia, that is CIN, or squamous cell carcinoma, is made on the basis of histologic criteria. You need histology to determine that whether it's a malignant or a pre-malignant lesion. And these risk factors run through all of them, as we can see. Exposure to ultraviolet radiation, a history of skin cancer, old age, male sex, smoking, HPV infection, and HIV infection. So the non-invasive one, or the pre-malignant ones, we have the cornea and the conjunctiva ones, and we need histopathology to differentiate between them. This shows the conjunctiva CIN. It tends to be associated with HPV infection, exposure to sunlight. It occurs in the interpalpebral area near the limbus. It has rapid growth in people who have HIV/AIDS. So we have two clinical forms. We have the papilliform type, and then we have the gelatinous type, and then the third type is the leukoplakic type, as you can see in all these pictures. Then we have the cornea type. The cornea type is, as you can see in the picture, also tend to be associated with HPV infection. Sunlight exposure that occurs in the interpalpebral area near the limbus. You have a granular translucent gray epithelial sheet from the limbus onto the cornea. Then the edges are fimbriated, as you can see. The treatment is with interferon. Then they tend to have a very high recurrence. Malignant tumors of epithelial origin, the commonest is squamous cell carcinoma. And these are the clinical type, the plaque-like, the gelatinous, and then the papilliform type. The location, the common locations are the limba, the bulbar, conjunctiva. They can extend beyond the basement membrane into the stroma with metastatic potential. So, by histologic definition, when you have atypia, epithelial atypia, that breaches the basement membrane, you have squamous cell carcinoma. The CIN, when the basement membrane is intact. These are the risk factors, and it's aggressive in people who are immunocompromised, particularly HIV/AIDS patients and people with xeroderma pigmentosa. The granular tumor, the granular conjunctival tumor. I will limit myself to sebaceous gland carcinoma, and it's a masquerader. It presents like recurrent chalazion or chronic posterior blepharitis. So if you see any patient with a risk factor that presents to you with this recurrent chalazion and chronic posterior blepharitis, you initiate a measure and it recurs. You need to initiate a measure and it recurs. Then you should begin to suspect sebaceous gland carcinoma. Then the tumors of neuroectodermal origin. The benign ones, we have freckle, which is a flat brown patch. Then we have benign acquired melanosis, which is increased pigmentation that is often flat and sometimes extends to the peripheral corneal epithelium. Then we have ocular melanocytosis, ocular congenital melanocytosis. Very interesting things about it. It is characterized by episcleral pigmentation, which is a focal proliferation of the subepithelial melanocytes. This entity, this presentation is what we call the blue nevi. Half of this, half is lateral dermal melanocytosis in V1 and V2. And this component is what we call the nevus of Otter. When you have blue nevi and nevus of Otter, you have an entity called the oculodermal melanocytosis. And this tends to be associated with glaucoma. 10% of them get glaucoma, and then 1 in 400 get uvea melanoma. So there's that risk that you have to take note. Then we have nevus. Nevus is a hematoma. We have the junctional type, the compound, and then the soft epithelial type. Nevi are usually flat. Then we have the pre-invasive type, which is PAM. PAM tends to be lateral. It occurs in light skin folds, flat, brown conjunctival epithelium. It is quite similar to benign acquired melanosis. Then you biopsy if it is suspicious. Atypia epithelium, atypia is a risk factor. Then you excise if you have atypia with the pigmentation, and sometimes you have to apply adjunctive chemo drops. Then the malignant form is the malignant melanoma, and 70% of PAM will transform into malignant melanoma, 20% of nevi, and then 10% arise de novo. It's important to know these worrying features. Then tumors of vascular or mesenchymal origin. The benign ones are the hemangioma, and then the inflammatory type, pyogenic granuloma. It's pyogenic because it tends to be associated with a lot of suppuration, a lot of discharge. Then we have almighty Kaposi sarcoma, which is a vascular endothelial tumor. It's been found to be associated with the human herpes virus 8. It's one of the key features of HIV infection. Then we have the conjunctival malignancies. Lymphoid hyperplasia is what we used to call the reactive hyperplasia. But what is dangerous about it is that it has a very high tendency to transform into a conjunctival lymphoma. Therefore, you have to take note of that. Then the lymphoma itself generally is a monoclonal B lymphocyte. And then it tends to present clinically the same way as a lymphoid hypoplasia. In 20% of cases, it's bilateral. And it's common among people older than 50 years or immunosuppressed. And we manage it. It's supposed to be managed by the oncologist. Then we have metastatic tumors. Important to note that as far as the cornea and conjunctiva are concerned, we don't have as much metastatic tumors affecting them as we do have for the uvea tract and the orbit. But there are some tumors like breast cancers, breast malignancies, lung malignancies, kidney malignancies. They can have secondaries manifesting in the conjunctiva. Right. So that brings us to the end.
I will just throw up this slide here, which I think is very important. I think when we do corneal transplants, oh, my internet is unstable again. When we do corneal transplants, if it's DOC or PKP, one of the things that we've got to contend with, apart from rejection, is astigmatism. And you're going to spend a lot of time managing astigmatism. And I think we need to understand how to manage astigmatism. Now, I like to group them into intraoperative methods and postoperative methods. You won't find this in your book. I made this up. And so, so intraoperative methods, you know, your technique, how tight your sutures are. So good suture technique, it should be, you know, the right length on the donor side and and it should be evenly spaced. Those are very important pearls that we need to carry home. If you don't place your sutures well whilst you're doing your surgery, you end up with a lot of astigmatism. So managing of astigmatism starts intraoperatively. Of course, you can use femtosecond lasers, you know, to help, but you know, most of us don't have access to it. You know, trophonation should be also perfect. If your trophonation is not good and it's tilted, then you have a cornea that is not looking very good. But then, when you're done, then you are done, and you have an astigmatism that is already there. And so there are various things that you can do. Whatever you do, you have to use topography to guide you in your astigmatism management. So remember, this is going to take 6 months to a year, up to 2 years in some patients, before you get a final refractive state that is satisfactory. And so post-op selective removal of sutures, you need to decide which sutures to remove. You remove sutures and then you flatten the cornea in the axis that you have removed your suture. So throughout your management, you've got to talk to the patients and do that. And then you can also do continuous adjustments of continuous sutures, again, using topography. Now, you can also do relaxing incisions. I do relaxing incisions quite a lot post-op. And that can relax and flatten a stiff axis. You could also go back and place a suture that's a little tight. I don't do that often. And if after removing all your sutures, you can do toric IOLs. Now, when you've done all that, sometimes you find that your cornea is still pretty not great. And so at that point, you might consider putting a contact lens on the ocular surface, and sometimes that helps. And so these are the things that I think every resident should pay attention to. When you've dealt with your intraocular pressure, your ocular surface, your rejection issues, you're going to spend half your time managing astigmatism from your shooters. Of course, DSEC and DMEC are exceptions, but even DSEC and DMEC, especially in DSEC where you have thick corneas, usually the corneas are not evenly thick. The posterior curve may give you a little bit of astigmatism, not as much, nowhere as near as the astigmatism you have with dog PKP. So having said that, I think I'll leave it here, and perhaps mention a few techniques that are coming up in the future, and so that we can some of you will be pioneers in doing these techniques. Before I do that, in children, it's very critical that they have I'll put this slide up, and I think I'll spend 1 minute talking about it. If you have a child that you want to do transplant on, you can do it technically. It's not a problem. At a post-op, guided prognosis, rejections are much more higher in children. There's a lot of post-operative glaucoma. They have strabismus. They induce trauma on themselves. You need to manage amblyopia, anesthesia many times. And if you have a child who cannot tolerate anesthesia, it's a problem. And there's an extensive ongoing care. So transplants in children is better if you do a lamellar transplant, so you reduce the risk. But you need to have a good discussion with the parents, with mom and dad, and walk them through the difficult years ahead. And mom and dad must be with you to work together to make sure that you have the best outcome as much as possible. Don't hurry to do a child transplant just because it can be done. You need to go through with mom and dad carefully, make sure they've understood what is involved. They may have to take time off work sometimes, and the economic impact. So these things have to be very carefully discussed with them. So having said that, I think I'll end here, and you can read about corneal autograft in your free time, and where you rotate the grafts. I did one a couple of weeks back, or maybe last week. You rotate it so the clear cornea comes into the visual axis, or you can take an eye from the other eye which is blind and transplant it. Same technique. Or if an eye is being enucleated, you can pick it up from the patient instead of throwing it away. You can use it, and if the patient has a corneal opacity in the other eye, you can use that to do that. So very interesting things that can be done. Keratoprosthesis, and those are very advanced. But you can save a lot of eyes who have multiple graft failures, Steven-Johnson syndrome, mucous membrane, pemphigoid, as Dr. Amoah mentioned. And so don't give up on these patients just yet. We can still, I know there are only a few specialized centers, even in the United States, and definitely in most other advanced countries, there are only a few centers that do them. How many centers are doing this in India? I don't know. And I guess not a lot.
The academic, the very academic corneal surgeons are doing this.
Yeah. I got a chance to do a couple when I had Jack with me. The results were not great. There was a huge retrolental membrane, and so it's a difficult technique with very poor outcomes. Glaucoma is usually the issue, but you can check the intraocular pressure with the regular thing. So you have to look at the nerves yourself. You need to do OCT and visual fields, and that's the only way you can tell whether your nerves are hurting or not. So on that note, thank you very much.